Welcome everyone. This is Dr. Sharad Jaitly from New York, your cardiologist on your favorite website, MuniMeterHealth.com, which is dedicated to teaching and educating you about the human heart and its illnesses on our two channels on our social media, if you will. And essentially, I want to thank you for your enthusiastic support in watching, learning, and sharing with all your loved ones, including all your colleagues, your residents, your fellows, your interns, and your students, and your consultants. So this way, we are growing tremendously with your response and support. And once again, thank you for supporting in my cause of spreading this education freely to all. Once again, welcome to MuniMeterHealth.com. As I always say, without any further ado, I like to delve into the subject matter, and the matter is what is acute MR? And that's the subject of discussion today. What is acute MR or mitral regurgitation? Well, first of all, understand what causes it. Well, we need to know that there's a fenestration in the valve that develops over a period of time and then now acutely results into a mitral regurgitation. Now, a classic example would be endocarditis, because obviously endocarditis does not happen overnight, but for several days to a week, this endocarditis process has initiated, a vegetation within the valve leaflet, and as a result of fenestration occurs and an acute MR sets in. Now, that's an emergency, by the way. So this is a medical emergency for all of you who are taking the boards and the exams and, of course, in clinical practices. The second important cause would be any ischemia, which is to the papillary muscles. So ischemia resulting into papillary muscle dysfunction or even in acute MI settings. So an acute MI obviously is a fully irreversible acute MR, whereas an ischemia actually may be reversible. So this could be an intermittent variety, if you will, that can occur in an acute MR settings. Now, it's very important for us to distinguish between acute MR and chronic MRs, and we'll do that also, because normally acute MRs are very, very severe. Remember that. So it's a very severe hemodynamic emergency, shocky condition, and we'll define the clinical features in a second. Now, what are the other causes of acute MR here that might occur? Endocarditis, papillary muscle dysfunction, and do not forget something like a chordae rupture that can occur. So chordal rupture or tendiny rupture, if you will, and all of those could be seen, or a flail leaflet in a setting of, say, Marfan's, or in a setting of, if you will, either in a setting of a Marfan's or either it's in a setting of mitral valve prolapse, if you will. So just so that we know that those are the other causes of etiology, other etiologies of acute MRs we are discussing in this one. Now, clinical features. Obviously, clinical features really depend upon what one sees. As heart rate being increased, the blood pressures are falling, and urine output is declining, obviously. So these are all signs of hemodynamic shock, if you will. And these things will really make the person look extremely ill, and therefore they need to be in the ICU or CCU settings where surgical consultation is perhaps already made, if you will, and as a result the surgeons are on the way as well while you're stabilizing the patient in the clinical features of this kind of hemodynamic shock. The S2 and clinically again S2 may not be heard, but S3 will be present, and there will be a pan-systolic murmur, if you will, and that will be heard during systole, obviously throughout the systole, but in the presence of pulmonary rales, because the patient may be in pulmonary edema, you may not be able to hear the pan-systolic murmur so clearly, obviously, because there'll be rales, and the patient will be in very, very impending respiratory failure, if not already in. And at that point, you'll have to assess what the oxygenation is in this individual, and as a result, one can really start seeing these patients deteriorate, and therefore you have to be very careful and put them on ventilatory support. Having said that, now let's understand what are the diagnostic features. Now, diagnostic features are very important. So we'll draw the echo here, for instance, and this is because bedside echo will have to be done, and these individuals, obviously, if you're looking at the apical view, this is what you will see. I'm drawing the right side, and then I'll draw the left side here. When I draw the left side, remember the left ventricle and the left atrium, the size remains normal. So LV and LA size, they remain normal here. And that is one of the distinguishing features, if you will, for our patients who have this level of acuteness in their MRs. So just so that you know, LV and LA size rather stay normal because there's not enough time to really hemodynamically compensate and increase in size. So LA and LV size will stay normal. Now here's your tricuspid valve, this is your mitral regurgitation. So in a setting like this, you will develop a mitral regurgitation obviously, and that will be pointed in this direction. And we'll show some mosaic pattern here, if you will, and that's almost a severe form of mitral regurgitation, if you will, and that's your MR. So the severity of the MR does not define the acuteness of the MR. Remember that, but it's the LA and the LV size that will really define the acuteness of the MR. If you were to do a Doppler, obviously one sees a Doppler, and then you could see if the velocity is running here in this fashion, you'll see a tongue-shaped systolic murmur, and this is a pansystolic jet, if you will, and the velocities could be anywhere from 3 to 4 meters per second, because this is a very, very high velocity jet. And therefore that translates by 4V square, if you will, to have the pressure gradient. It's almost like 64 millimeters mercury. So you could go up to 64, 70 millimeters of mercury, and as a result the PSP pressures are also high. So the PSP pressures, pulmonary arterial systolic pressures, are very, very high, and that's what throws these patients into pulmonary edema. So diagnostic features are very clear. LV, LA size normal. Mitral regurgitation is severe, but that's not diagnostic because that you could have even a chronic MR settings. The chronic MR, remember, the LV, LA size will be enlarged. So LV, if it's enlarged, and LA, one of the hugest LAs you'll see in the entire cardiology world, and that's from a chronic MR, remember that. So chronic MRs will give you these features. So that's a very distinguishing feature. If they give you, sometimes they might give you the dimensions on the echo boards, and many times they will actually show you the size of the LA and LV, and then you measure it, and you find that these are very, very high, high dimensions. Then automatically put that into a category of chronic MR. It's not the acute MR you're dealing with in that problem. So just remember that. Now, so this was the continuous wave Doppler, if you will. And this was your 2D color, if you will. And that's one of the diagnostic features of this thing. Now the treatment plan. The treatment plan will be very, very geared towards obviously the hemodynamic shock. So you want to have obviously positive inotropies. So positive inotropics will be helpful. Afterload reducers, very important, because vasodilators or afterload reducers will be helpful in all the settings. Intra-aortic balloon pump. Do not forget that. That's a very, very important entity. I mentioned that on a different video when I was doing the acute aortic regurgitation. That's where the intra-aortic balloon pump is contraindicated. But intra-aortic balloon pump is a life-saving measure before the patient goes for surgical intervention in a setting of acute MR. Remember that. So very, very important, intra-aortic balloon pump. That should be marked there. But it's a no-no in acute ARs, just mind you. And of course, these patients should be referred for surgical intervention rather very, very quickly. In a matter of few hours, they should be seeing the surgeons in the OR. So the whole idea is wanting to stabilize as fast as possible, so this way the hemodynamics do not worsen, and obviously pulmonary arterial pressures are extremely high. Patient goes into pulmonary edema. So these patients are becoming hypoxic. They have hypoperfusion, severe hypoperfusion, all signs and symptoms of hemodynamic shock, renal failure, and all that bit. So, you have to be very, very quick in diagnosing, and the suspicion should be high, especially in a setting when you're looking at a Marfan patient, for instance, who suddenly deteriorates. A patient who has endocarditis who suddenly deteriorates and has a murmur now, a pansystolic murmur. A person who is now becoming increasingly shocked, like hemodynamic shock is setting in, where you have tremendous tachycardia, low blood pressure, urine output is falling, and S3 gallop is being heard, and patient goes into pulmonary edema and respiratory failure. Now, differential diagnosis, remember, many of these patients could be, especially in the setting of endocarditis, could be mistaken for a bad pneumonia because they have pulmonary failure. So just remember that respiratory failure does not mean, or sometimes they could be, so the differential diagnosis here could be ARDS and or pneumonia, if you will. So just remember that. Again, a chest x-ray will be very helpful, obviously, because, but still the echo is diagnostic because you can miss the mitral regurgitation of a severe nature in a setting of LV and LA being normal. Okay, and then of course these are your features where the velocities are tremendously high. Okay, I thank you for your attention. I hope this was a quick video vignette on acute MR, which is definitely going to be on the boards one way or the other. And of course, in clinical practice, one comes across, and this is in medical emergency, remember that? And that has to be tided over in an ICU setting. The diagnosis and the suspicion has to be high in order to make the clinch the diagnosis rather quick. So that's your nutshell here in acute MR. So stay tuned then for more stuff coming down MuniMeterHealth.com. And thank you for watching MuniMeterHealth.com on your favorite website. Our interest is primarily to gear you with the best information we can in a capsulated way in a smaller video vignette form. So this way you are ready to take the boards the next day or what have you, etc., or deal with the problem as you come along. Thanks so much, and again, so long. This is Dr. Jaitly.